right, with that, I leave it to Dr. Winstein.
Good morning. Welcome to our first DUR board of 2005. It's my pleasure to start my term as chair, and I want to express my appreciation for all of you who continue to volunteer to serve on behalf of our Utah Medicaid population. I think we have just a couple of orders of business known as there. A welcome new member that we wanted to open the meeting with.
Thank you, Dr. Winston. Yes, we do have a new board member, Dr. Laura Britton. She is replacement of Eric Kennan. Dr. Britton, did you want to say something to the board?
Yes, thank you. It's a privilege to be on this board, and I appreciate the opportunity to represent all 4 of Medicaid's ACOs on this board, and I look forward to working with all of you. Thank you.
Thank you so much. I think we have first order of business then, if we're at quorum, is to review and accept the minutes of our previous meeting from December 2024. Has everybody had an opportunity to review? And if so, if there are any comments? Otherwise, if there are no comments, we'll take a motion to approve our minutes from the December DUR board.
Motion to approve.
Thank you. Do we have a second?
I'll second.
Thank you. We say all in favor? Aye.
Aye.
Any opposed? No, thank you. Minutes are approved. We can move to then our agenda. I would just say if there's anything process-wise as I'm going that needs to be corrected or what, I've dusted off my Robert's Rules of Order. So I just wanted to say that. Please feel free to put something in the chat or raise your hand. Thank you. Our first order of business, Noon, if you would proceed with the agenda. Thank you.
Yes. So there's also another few housekeeping item. We also have a new pharmacist staff with Utah Medicaid. Ashley, would you like to say something to the board?
Thank you.
Hello all. Thank you so much, Noon, for the kind introduction. My name is Ashley, and then my official name is Kyung Park. And I graduated from the University of Utah Pharmacy School May 2023, and then I started my Medicaid pharmacist job 2 months ago. It's my great pleasure to meet you all. Thanks.
Thank you.
Thank you, Ashley. Also, there's there's an announcement that with Brian's departure, I will be taking over the PNT manager to manage the PNT committee. With that, the DUR board will be start to be managed by Stephanie Byrne, starting with next month. And you will be receiving email from Stephanie regarding the material and any other related to the DUR board.
And unfortunately, I was just going to say, and unfortunately, she's not feeling well today. Otherwise, she would be here to introduce herself. So sorry about that.
Sorry to hear that.
I'm actually here. I can stay on to.
Oh, I'm just kidding. I thought you weren't feeling well, Steph. I'm sorry.
It happens.
Well, thank you all again. For your any changes to our responsibilities plus our new members. We really appreciate that. Thank you.
Thank you, Dr. Winston. The next item on the agenda is the PNT update. So PNT committee will meet next month to review the EGFR inhibitor. That's all for the PNT update.
Okay. I just need to see what is our first agenda item and our first presenter. we can welcome them.
Yes, the first prior authorization will be present is the Amondas, Exodus, and Eviondis. The TEPSO prior authorizations, but look like we also has a public comment request. Maybe we let the public comment go first.
Okay, I apologize. I'm in a remote location and I'm trying to get my split screen so I can see the agenda. So appreciate your help with that.
Thank you, Dr. Weinstein.
Do we have a public comment? Is that person with us?
Hello, good morning. My name is Armin Cacciatorni. Can everybody hear me?
Yes.
Thanks. I'm with Sarepta Therapeutics, and so I was just online here. The policies are written to label, so I wanted to just go ahead and provide. I'm not going to provide any commentary and give my time back to the group, but I did want to make myself available if there are any questions that I can help answer as these discussions progress.
Thank you so much.
Of course.
Is there any other public comment?
I think good morning. I've signed up as well. Good morning. My name's Jill Connor. I am with U.S. Rare Disease from Sanofi and just wanted to talk a little bit about Fabry disease and Fabrazyme, which I think that you're covering. So just very briefly, background on Fabry disease. It is a rare disorder. It's an X-linked genetic disorder caused by a deficiency of the lysosomal enzyme alpha-galactosidase A, which leads to an accumulation of the substrate global triacylceramide or GL3. And these patients, they affect both males and females, and they experience that progressive accumulation of GL3 over time. Ultimately, these patients can have significant clinical manifestations. Classic Fabry disease patients can have neuropathic pain, they can have GI complications, cardiac arrhythmias, cardiac failure, stroke, and progressive renal disease. Fabrazyme is a hydrolytic lysosomal enzyme. It's specifically indicated for the treatment of adult and pediatric patients, ages 2 years of age and older, with confirmed Fabry disease. And Fabrazyme is basically the exogenous form of the enzyme, which is internalized and transported into the lysosomes, where it basically exerts their enzymatic activity and reduces that accumulated GL3. There's been a lot of clinical data from a clinical perspective on Fabrazyme. It's been studied in classic and non-classic Fabry disease patients with early and advanced disease. It's been studied in pediatric patients as well as female patients. And so I'm not going to go into, we've been approved since 2003, so there's a lot of data, so I will not go through everything for you, but just a very recent study that was published as a long-term observational study in 122 Fabry disease patients. And it looked at those patients against a historical control of untreated patients. And the median duration was 3 to 4 years. Looking at that estimated eGFR slope, there was a decline of a negative 1.5 mils per minute in the Fabrazyme group and a negative 3.2 mils per minute in the untreated group. Fabrazyme was associated with a lower risk of clinical events, and those included the stroke, cardiac events, etc. From a safety perspective, patients with that have been treated have experienced life-threatening hypersensitivity reactions, including anaphylaxis, and there is a black or boxed warning now on the package insert. In clinical trials and post-marketing safety experience, approximately 1% of these patients developed anaphylaxis or severe hypersensitivity reactions, and approximately 59% of patients experienced infusion-associated reactions. So if anybody has any questions, happy to entertain those. But thank you so much for your time today. Happy New Year.
Thank you. Do we have any other anticipated public comments on this?
That is the only two for today.
Thank you. Then I think if we can, we're considering the prior auth, is that correct? So thank you for bringing that up.
Yes, so this is the proposed prior authorization for Amondas, Exondys, Viondis, and Viltepso. The criteria for approval, all of the following criteria must be met. Does the patient has a confirmed diagnosis of Duchenne's muscular dystrophy? Is the medication being prescribed by or in consultation with a provider specialized in the treatment of DMD? Has the patient been on a stable corticosteroid dose for at least 6 months unless contraindicated or intolerant to the therapy? Has the patient received gene therapy for DMD, such as elevitis? If yes, does the patient experience a worsening in clinical status seen receiving gene replacement therapy? Additional criteria for casimersen, does the patient have a laboratory confirmations of DMD gene mutations amenable to exon 45 skipping diagnosis by genetic testing? Or for eteplirsen, does the patient have a laboratory confirmations of DMD gene mutations amenable to exon 51 skipping diagnosis by genetic testing? Or for the golodicins, does the patient have the laboratory confirmations of DMD gene mutations amenable to exons 53 skipping diagnosis by genetic testing? For butylarsins, does the patient have the laboratory confirmations of DMD gene mutations amenable to exon 53 skipping diagnosis by genetic testing? An additional questions for the two that is indicated for exon 53, golodicins and butylarsins, will the patient will be using them in conjunctions with each other? Reauthorization criteria, has the provider submitted an update letter of medical necessity or updated chart note demonstrating positive clinical response to therapy? Initial authorizations, we allow this one up to 1 year and re-auth up to 1 year. We also have consult Dr. Russell Butterfield on the criteria for his professional opinion, for his expertise opinion as well.
I see a hand from Dr. Smith.
Yeah, sorry, I'm just a little confused here because what we got in our email was a prior auth for Fabry disease. And this is a prior auth for DMD. I know the medications are the same, but I didn't review DMD because I got different or their authorization to review. So I'm just trying to figure out what's going on here.
Oh, there's two prior authorization included in the email. The Fabry disease and this one. They might be buried within a lot of other documentation.
I don't see it anywhere.
We had two communications from noon on this, and it might have been on the earlier one. No?
Mm-mm. No, the one from the January 2nd had minutes, Fabry disease, another Fabry disease. Sorry, that's El Fabrio prescribing information. Yeah, I have a lot of prescribing information here. I don't have a prior auth from DMD.
Oh, it is named Amondus 45 Exondus. It's a lengthy name to the prior art.
Ah, got it. Okay, thank you.
Do we need to, Dr. Britton, have a question or a comment, please?
Thank you, Dr. Weinstein. I actually put a comment in the chat. The ACOs just had a little bit of feedback on the criteria. We think the criteria is really good. Just had some other suggestions to add to it. One of them was to be able to understand how the disease is improved through the therapy. So we recommend that we get some baseline documentation to help us to measure the clinical benefit of improvement. And so I put some examples in the chat. And also it was a recommendation that we include some age, dosing, and quantity limits for each drug.
So I'd say the two parts to that. And I think if there's a group consensus, at least on the first part, under criteria for approval, that might be a modification of number 2, where the medication is being prescribed by or in consultation with a specialist, to include some documentation. I know with a lot of functional status is important, and to have some objective criteria where they exist. As you all know, I'm a pain doctor, so that's one of the banes of our existence, is looking for objective criteria. But I think you have put some in here. So if we have, if we want to include this, then we would, if there's more discussion, or if somebody wanted to propose an amendment to the criteria that incorporates that first part of the chat. The second part, I'm not sure. I think that's a technical question to the group. An administrative question is when we make these prior auths, if we're including the age and dosing limits, or is it assumed that that's following prescribing guidelines. So I'm going to put that out as a question. So first, if the group is inclined, we would need a motion to make an amendment, and second, some discussion on the age and quantity limits being embedded in the prior auth. I just had one grammatical thing. The first time we abbreviate DMD, we can do that earlier in the document and then just use DMD throughout. If somebody wants to just tweak that a little bit. Open to discussion, please. Our guest speaker.
Good morning.
Did I say that correctly?
Carmen Cacciatorian, yes, thank you.
Thank you.
Good morning. With regards to just some of the commentary on age, so all 3 of these products are approved by the FDA without any age restrictions. I just wanted to be clear on that any age restrictions would be outside of the prescribing parameters by the FDA. And I'm not sure I caught all the other additional changes, but as far as baseline functionalities to assess improvement, I want to be clear that the goal of therapy here is stabilization, not necessarily improvement. So I'm not necessarily sure that anything beyond physician attestation of clinical benefit would be really meaningful for understanding how the patients are progressing.
Thank you. Dr. Britton?
Hey, I would be interested in knowing what our neuromuscular team would feel about those additions. I know some things are routinely measured, some are not. Some are things that will help you guide how the medication is doing, some will not, as we discussed in a couple of prior meetings as well. So I would feel uncomfortable approving these things without really knowing what the clinical impact is. And yeah, so I would love to get that input again from Dr. Butterfield or someone like that.
Dr. Britton?
Yeah, just a couple comments about what the gentleman mentioned. As far as if we don't have any, clinical documentation of what is actually happening with the patient, it is difficult to assess whether the therapy is effective. So having some objective measure, regardless of physician attestation, I think it's very helpful given the cost of these drugs that we are able to assess that clinical efficacy. And then with respect to age and other limits, there are trials, clinical trials where these drugs were performed. And that's where we would recommend that the age follow at least where the evidence is.
Mr. Cacciatorian?
Thank you so much.
Sure.
I totally appreciate all those comments, and Dr. Britton and everybody. It's more of a concept of our clinical trials, again, were designed to try and homogenize these very diverse patient populations, not necessarily be representative of the entire DMD population. I think it penalizes patients that fall outside a kind of a very specified homogenized grouping who would still benefit from the mechanism of action of these type of therapies. So we just put that into consideration, and obviously with discussion with Dr. Butterfield or any other neuromuscular physician, I'm sure we feel very similarly. But that being said, again, I would think it's warranted to again have more feedback from the neuromuscular specialists who would know better on these topics.
So this PA has been reviewed, and the criteria has been modified based on Dr. Butterfield recommendations to this, and as there is an age limit in the clinical study, there is no age in the indications of the drugs, and Dr. Butterfield has mentioned that these drugs might have slowed down the progressive of the disease, unlikely to see any change in functional over the time period. So the REOT criteria also have been modified based on his comment.
Dr. Smith, you look like you're about to say something.
Yeah, I would just say that I'm comfortable with the PA as written. I don't feel like there's additional additional measurements or documentation required other than physician or prescriber attestation.
Any other comments? Then I think the only edit I would make is just the typographical one, and that's not substantive. If there are no more comments, I would entertain a motion to accept the pre-auth document as it's written. Dr. Smith?
I move to approve.
Do we, and we have a second. Thank you both. All in favor? Say aye.
Aye.
Aye. Any opposed? Okay, thank you so much. I know these are, although still somewhat rare diseases, when they do affect our families, it's very significant. So we appreciate the opportunity to provide treatment as indicated and in coordination with appropriate specialists and support. Thank you. What's next up on our agenda?
The next on our agenda is Fabry disease, PA.
Okay.
Can everyone see the prior auth? Perfect. Good morning, everyone. So I have this PA for Fabry disease. It includes Elfabrio, Fabrazyme, and Galafold. And thank you earlier to Dr. Connor for the background information on Fabry disease. This prior auth is a little more straightforward. So first criterion is, does the patient have a diagnosis of Fabry disease confirmed by enzyme or genetic testing? And is the medication being prescribed during consultation with a provider specializing in the treatment of this disease? Just because there can be a multitude of specialists who are involved in providing care for these patients. Those are the two general criteria. The three following are specific to each drug. For Elfabrio, it's only indicated for adults. For Fabrazyme, it is indicated for patients 2 years of age or older. And then Galafold has a few more restrictions. It's only indicated for adults. It also requires the patient to have an amenable galactosidase alpha gene based on in vitro assay data, and it is limited based on the patient's kidney function. So if they do not, they have a eGFR of less than 30 mils per minute, it is restricted as well. For reauthorization criteria, it's the same as previously. Has the provider included an updated letter with medical justification or updated chart notes demonstrating positive clinical response? And we've included the boxed warning for Elfabrio and Fabrazyme, for hypersensitivity reactions. For these patients, guideline recommendations recommend using one of these agents. It's usually dictated based off of insurance coverage or the additional criteria below. And one of these therapies is recommended in addition to supportive care. So that's why these are less specific criteria. Are there any questions? Dr. Smith?
So not so much a question as a correction, I guess. Since the Galafold, under Galafold, it says criteria above must also be met. So this is about meeting criteria. So they have to have an eGFR of greater than 30.
Correct.
Okay, so the greater than less than sign should be flipped, no?
It just depends on whether they answer yes or no. So we can change it either way to clarify. So I'm happy to do that.
Okay, because yeah, you don't want them to think that they have to meet a eGFR of less than 30. They
Right.
get excluded, right?
Dr. Britton?
Yes, again, the ACOs had a couple comments on the criteria, which I put in the chat. Again, in order to make the review of these medications easier on the reviewer, oftentimes physicians don't have a specific attestation one way or another. It would be good to have baseline disease status measures that are listed in the criteria, as well as the recommendation that the provider attests that they do not combine therapies. Thank you.
I have a question for those of you in the group that are more directly involved in the care of these patients and or the reviews from the pharmacy side. It's been a while since my basic neurology where I would have seen any of these patients. Is there any clinical practice I'm concerned about, or question related to the second part, again, from the ACOs. Do clinicians outside of these kinds of standard approval guidelines ever combine the therapies purposefully? Does that happen? Do we know?
So if I may, based on my research on the topic, these are all recombinant enzymes for replacement therapy. I do not see any recommendations to combine them for therapy, which to me theoretically makes sense if it's recombinant enzyme therapy.
Right. So our attestation that the clinicians wouldn't combine the therapy, I was just wondering what the, was that targeted to a certain issue?
So in this PA, there is no criterion for that, although I can include one if that is what the board recommends.
Dr. Britton,
So
maybe you can clarify for us. Thank you.
yeah, sorry. So just to clarify, oftentimes, regardless of whether it's clinically indicated or not, we do see for different disease states, Fabry's or not, but occasionally they will try to combine these super expensive therapies. I don't have any specific examples, but if it's here, one of the ACOs obviously felt a concern about it.
Okay. Our focus, I think we have another hand up. Sorry, Jill.
Yeah, no, my apologies. I just wanted to say in the treatment guidelines for Fabry disease, there isn't anything that ever would recommend that those products be together.
Thank you. Right. I can't infer a clinical rationale to combine them. So I was just wondering, like, is this something that's been seen where we felt like we needed to add this in? Our purpose in this board is to really focus on the clinical criteria, the authorizations, any discussions for community provider education and things like that. Many of the things we review do have significant cost burden, but that isn't the focus of this group. But I was just wondering, the rationale must relate to some clinical instances of people trying to do this. Any further discussion? I had only one minor edit too. If we have the generic and trade names for the products in the document, I'm not able to, to scroll it right now, but that would just be one thing to make sure.
Yes, I can do that, Dr. Weinstein.
It's just a minor edit again. Any other, if there's no other discussion, is there, somebody want to make a motion for any amendment or to approve as written? Dr. Smith?
I move to approve with the edits that we discussed. The greater than, less than, and add addition of the brand names to clarify.
Do we have a second?
I'll
Second.
second.
Thank you. All in favor, say aye.
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 I'm
Any
sorry.
opposed? Sorry?
I'm sorry, who, can I have a record of who seconded the motion for the minute?
I saw two, I think, including Dr. Britton.
Yeah, I'm happy to give it to the second.
Oh, sorry.
Thank you, Dr. Britton.
Thank you.
Oh.
Any opposed? I don't. Okay, thank you. Appreciate that and our discussion. Do we have any other agenda items to review?
That is all for our meeting today.
Okay, thank you, everyone. I'll take a motion to adjourn.
So moved.
I believe I can second it. Thank you very. It's a little transition day, so again, appreciate everybody's patience with me, and I thank you for your time this morning. We will see you in February. We will look for a communication from Stephanie, who will be stepping in for Nina. She steps in for our previous manager. Thank you so much, everybody. Have a good day.
Thank you.